Looking to elevate your COMLEX prep? Dive into RemedyOMM.com. Discover our comprehensive question bank, expert lectures, and personalized consultation services, all tailored for your success. Join the community of achievers. Visit RemedyOMM.com today and take the next step in your medical journey.
Hello everybody, welcome back to Remedy OMM. Today we will be going over one of the more complicated topics, ribs. This is part 1 of the ribs series, and we will teach you high-yield basic anatomy and function. Just some basic anatomy here, very low-yield stuff, but simply putting these images here for completeness. There are 3 key landmarks to know. The first is that the sternal notch correlates with the vertebral body of T2. The second is the sternal angle, which correlates to the vertebral body of T4. And the third is the xiphoid process, which correlates with T9. There are a few key elements to learn about to master rib dysfunctions. First is the classification. There are 2 sets of classifications for ribs. True ribs, which are 1 through 7, and false ribs, which are 8 through 10, versus the floating ribs, which are 11 and 12. True ribs attach to the sternum directly. False ribs attach to the sternum indirectly, and the floating ribs do not attach at all. This classification system is much lower yield, but good to know at least that it exists. Typical ribs are from 3 to 10, and the atypical ribs are 1, 2, 11, and 12. Typical ribs have a tubercle, head, neck, angle, and shaft. Atypical rib is missing some component of the above. An easy thing to remember here is that atypical ribs have 1s and 2s in them, aside from rib 10. The next key element to understand regarding rib motion, test makers love this stuff. There are 3 primary motions of the ribs: pump handle motion, which is exhibited in ribs 1 through 5, bucket handle motion in ribs 6 through 10, and caliper motion in ribs 11 and 12. An important piece of information is to understand that the ribs will move superiorly with inhalation and inferiorly with exhalation. This movement is directed by the muscle attachments. The primary muscles of respiration include the diaphragm and the intercostal muscles. The diaphragm is innervated by the phrenic nerve. Remember, C3, C4, C5 keeps the diaphragm alive. And so as we see in the picture on the right, during inhalation, as the diaphragm contracts, it flattens the lungs, which creates negative pressure, filling up the air with lungs. As the diaphragm relaxes during exhalation, it moves upward and the air is released. The external intercostals help with inspiration, while the internal intercostal muscles and abdominal muscles contract for active respiration. Knowing the secondary muscles is very high yield, especially when it comes to treatment. With that being said, there's a fair bit of overlap of these muscles. However, test makers focus on the unique rib insertions for each muscle. So, I've simplified the attachments for ease of understanding and memorization. The anterior and middle scalenes elevate rib 1 with inhalation, while the posterior scalene elevates rib 2. The pectoralis minor attaches to ribs 3 through 5 and are innervated by the medial pectoral nerve. The serratus anterior attaches to ribs 6 through 8 and is innervated by the long thoracic nerve. Damage to the long thoracic nerve can lead to medial scapular winging. The latissimus dorsi attaches to the ribs 9 through 11, while the quadratus lumborum attaches to rib 12. It may seem like a lot at first, but with repetition it will become easy. Again, a very high-yield topic that I highly recommend you memorize. That's it for the basics. Check out Ribs Part 2 for diagnosis and treatment. Please like, subscribe, and support our channel. If you have any questions, please don't hesitate to comment below. We will see you guys in the next lecture.